Head up high, shoulders back, and remember, you that bitch.
There's nothing you can do to convince me that God did not take an extra day creating me. I mean, look at me.
So I'm gonna break this up in part 2. Okay, this is gonna be the first part, and the next one I upload next week will be the second part.
Today I'm gonna be doing a video on how to kill it during your preceptorship / orientation. As you know, if you may be starting a new job as a resident, my program, we got 16 weeks of orientation. And on my own now, and all these strategies and tips I'm about to give you guys has helped me to be successful in a way on my own, so I'm not running around the floor like a chicken with my head cut off. 3 days straight I worked by myself, and what happened, and it was very chaotic.
And I actually got recognized during huddle in front of all my fellow coworkers about how I handled the situations, and how my nurse manager she's been telling me how well I'm doing with my time management, because that's the biggest thing that new grads struggle when they become on their own.
So I feel like, oh my God, like whatever it is I'm doing is working.
And I love that for me. So I'm here to share some tips and tricks with you guys about what I've been doing to kind of like stay on my P's and Q's, and just to kill it during your preceptorship, okay? And from when you get on your own, because you know you're gonna be struggling at first because we don't know everything.
So my first tip and trick is to be confident, not arrogant. Remember, there is a thin line between arrogant and confident. Arrogant is self-inflicted. It's like you tell people what you're capable of. Confidence is they already see it on you. Like it ain't on me, it's in me. That's like what confidence is. So remember to, you know, tread that line carefully. Confidence people can see. Arrogance is what you exert, like you trying to basically overcompensate for your insecurities. So your patients know where you're not confident, you don't know what you're doing. If you don't got it, just fake it till you make it. Your coworkers know where you're not confident, and they would try you, especially older seasoned nurses, they will try you. But when you on your shit, you don't have to worry about that. So head up high, shoulders back, and remember, you that bitch. I was clocking in early, like to come in to look up my patient. So sometimes you will get a shitty bedside shift report. So coming in and looking up your patients early will give you a better idea of what you're walking into, and then you'll be able to know your patients a little better and what you need to focus assessment on.
So I basically get in a routine when I come in early of writing my own bedside shift report, and anything that the nurse saying that I don't have in my report, I just clarify with them and just ask questions about it. And I don't be in there asking, oh, did they pee today? Come on, just don't be one of those nurses. Like,
organize yourself. Get a routine. So my routine, particularly because I work on a cardiac floor, the first thing I do when I come in, like I said, I look at my lab. So because I'm a cardiac post-surgical floor, I look at hemoglobin, hemocrat. A lot of our patients, they're post-surgical, so they could just be bleeding, we not even know it, so we have to watch those labs. I look at troponins, we a cardiac floor. A lot of people come in there with crazy high troponin levels, so I need to see if they're trending up, trending down. I know if you have a hemoglobin level like below 7, you need to start transfusing, so I look at that. I also look at potassium. Potassium is one of the big things. A lot of our patients are on Lasix, and believe it or not, they don't really give patients diuretic that spares the potassium. So like the other day I had a patient on the Lasix strip. Her freaking potassium came about at 2.8, critical. So lab usually will call you, let you know it's critical. But in the meantime, like I said, I'm on a cardiac floor, so I have to watch those labs like that, like are they trending up, trending down, so that I know I can follow the protocol. And sometimes a lot of the potassium is going to be like PRN, so you have to look at the lab to even know how and when you're going to replace them, because you know potassium plays a big part in how the heart beats and how it contracts. So if it's too low or too high, you already throw it off and throw your patient into arrhythmia. So that's another one. Another one I look at is PT and INR. Because we are a cardiac floor, we have a lot of patients on heparin, we have a lot of patients on Lovenox, a lot of patients on Brilinta, all kind of blood thinners, warfarin, all of those things you've been learning in nurse school, you have those patients. So I have to look at the PT and INR. If a patient is on a heparin drip, I also have to look at when is the next heparin essay due. So you know you have to be therapeutic twice. Platelets, like I said, because if I'm giving you Lovenox or heparin injection sub-Q, I can't be giving that if your platelets are a certain level. If you are a nursing student, comment below when you should hold Lovenox or heparin. Tell me below if your platelets are what, when should you be holding that? Because as a new nurse, you just thinking the Mars telling you give this medication, But your critical thinking skills need to come into play and know like, okay, maybe I shouldn't give that because they look like their platelets are either trending down or up. If they're trending down and they're low, you might want to hold that med. So that's another thing. Yeah, you are a glorified drug dealer, but you got to know when to get a drug and when to hold a drug. Start getting in the routine of looking up like your lab. Another thing that's helped me be very like a superstar on my orientation is organizing my day. Time management and organizing my med pack. About who you want to go to first, who you want to go to last, and what patients are AccuChecks play a big part in that. Because if you're AccuCheck, I want to get you your insulin before your meal comes, so I want to kind of prioritize that too because I want to cover you on time. Go to your patients who take the less time first. So for me, I save my more needy patients last because they're going to take up a lot more of my time. I save my more like non-ambulatory patients last because they're going to take up a lot of my time.
But like patients who have like NG2s, you gotta crush their meds, they're very needy, they call you in and out the room, I save them for last because if I've got our patient ratio is 3 to 5. Most days, if it's a good day, we'll get 4 patients. So if I got a 4 patient day, I'm gonna go see those patients last and I'm gonna go see my other patients first. That way, by the time I get to them, I'm caught up on my med pass. I can give them the extra time they need from their nurse without making them feeling that I don't care or I'm rushing. You know what I'm saying? Because sometimes those patients just need a little bit of time. That's it. And I'm telling you, it'll make a whole difference in your day.
If I have a quick med pass, I'm going to get you out the way first. Or I will prioritize anybody who's in like a lot of pain. Because like I said, I work on the post-surgical floor. So if you just had a TAVR, you just had a cabbage, I'm going to come see you first. Because they just open you all the way up and did all kind of vein harvests. So I'm gonna come give you your meds first. I also prioritize any patients that have any acute changes overnight, especially if my patient, they just called the rapid on my patient. I'm not gonna save them for last. I'm gonna go see them first. Okay, another thing that will help you greatly is to cluster your care. And not only when you're clustering your care, you have to be sometimes very assertive with your patients about this. Because sometimes patients get into my frame of thinking that they're your only patient and they will take up a lot of your time. So a lot of times if I get a feel that they're one of them patients, if I went in the room a couple times and they're like, every time I go out the room, they're like, hey, and another thing, oh no, we're not gonna start that. Like you gonna have me running in and out your room? No. I like to set the expectation as I have other patients, I have to go see other patients. While I'm here, is there anything I like to cluster care so I'm not running in and out of your room all day, and so that I can divide my time between all 4 patients because you all deserve proper care. And a way of doing that with your patient is just to address their 5 P's. So I'm gonna go over the 5 P's. And if you do this, I'm telling you, it's gonna save you a lot of time. And you set the expectation like, listen, I have 3 other patients today. Some of my patients are critical, some of them are not. While I'm in the room, I just want to let you know anything you need at a time or before I come in your room to let me know prior to coming into your room. I would like to cluster your care, do everything at once, and get all your needs met at this time. Patients respond well to that because they understand, okay, I can't be doing the most. I'm not the only person she has. So the 5 P's are pain, position, potty/personal hygiene, periphery, and pump. So let's go to first P, pain. That looks like asking a patient, are you in any pain? If you is, could you rate your pain from 1 to 10? 10 meaning you got hit by a bus. Okay, is there anything you would like for me to do for your pain? Would you like a pain med, an ice pack, a hot pack? What would you want me to do for your pain? So addressing their pain. Position, now looks like asking your patient, are you comfortable? A lot of times you go in the room, your patient, they look like they're uncomfortable. So I ask them, are you comfortable? Can I move you? Can we adjust you? And you need another pillow, something, like let them know. Do you need to be repositioned? And a lot of times patients, believe it or not, they will be on that call like all day because nobody took the time to ask them, hey, are you comfortable? Do you need to be repositioned? A lot of times they just want somebody to slide them up. Like we have cabbage patients, meaning they don't cut your whole chest open. You really don't got the strength, or your body doesn't have the pain tolerance to be trying to slide yourself up. You know what I'm saying? So that's very important. So try to address those things when you go in with your patients. So potty, oh my God, like I said, that's another one of the things that they beat on that call like all day about pottying. So ask your patient, do you have to use the restroom? If your patient is a fall risk, while I'm in the room, I would like to take you to the restroom. Do you think you have to pee at this time? Like we have patients on Lasix drips. That is a diuretic, so they go all day. Some of those patients, they don't understand that they're at risk orthostatic hypertension, meaning when if they change positions, they can easily faint. So they don't understand that far risk. So educate your patients. Sometimes just educating them will solve a lot of your problems. Let them know, I like to take to the restroom. If you do have to use the restroom, make sure you use your car light. Please do not get out of bed on your own. If we do experience an episode where you're getting out of your bed on your own and I think it's unsafe, I will put you on a bed alarm. When you threaten them with the bed alarm, they get their stuff together. Because I'll tell my patients straight up, like, in my head, I'm like, this is my license. If you refuse the bed alarm, you're going to sign a paper. If you refuse to wear your yellow socks, you will sign a paper. You got to let them know that you're confident in your decision making and you want to keep them safe at all times. So take them to the restroom while you in there. That's not always a tech job. If you in there, just do it. Only thing I usually don't do is the blood sugars. But if I'm in there, if my patient dirty, if anything going on, if I have a bedridden patient and they poop, I'm not no better than my tech. I would change them. I would clean them up while I'm in the room. I would do as much as I can as time permits me to do that. And your patient will realize, like, oh, they in here helping me. They'll really take heed to that. Pumps. Check your lines, make sure they're dated, make sure they time, make sure they're running. I remember one time I was doing, and I don't know what it is about shift change, but everything goes wrong doing shift change, especially on my floor. We get rapids doing shift change. It just be a lot of BS going on. Pumps. I remember one time during shift change, we had a patient on a heparin drip. If you know anything about heparin drip, you do not want to stop those pumps for long. And we got raggedy pumps at our hospital, so they go dead as soon as you unplug them. We keep them plugged in at all times. Make sure your pump is plugged in at all times. So God forbid you got a nitro drip, a heparin drip, any type of critical drip, and then your pump not working. And you run around the hospital trying to find another pump. So during bedside shift report, we go in, we give a report, and the nurse, oncoming nurse is like, the pump is off. I was so embarrassed. Cause like that makes me think, like, damn, she wasn't doing her job. Like, her patient pump is off, and it ain't no telling how long the patient pump had been off. If you're on a heparin drip, it's probably because they need to thin your blood fast and quickly for some type of procedure, or because you have blood clots or something's going on. So check your pumps, check your lines, especially if your patient has positional IVs. Please do that on your rounds when you go in your patient's room. So that can help you. And if you do that with your preceptorship, they'll be like, oh, she know what she doing. You use them 5 Ps, they're gonna be like, yeah, she one of them. She's one of them. Yeah, I'm gonna make a part 2 because y'all know y'all overstimulated. Attention span is trash. So I'm gonna break this up in part 2 of how you can be a rock star during your preceptorship, because I don't want to overload y'all with information. And now I will be doing pop quizzes in the middle of my videos so that I can keep those